All right, let's talk about OCD. Um, this is one I have a hard time with this one because this is one of those disorders that we tend to talk about really casually in everyday speech. Oh, I'm so OCD about cleaning or whatever. Um, and I've been guilty of talking that way myself a few times. Um, but if you think about it, obsessive compulsive disorder is uh, the intrusion of unwanted thoughts leading to compulsive behaviors that cause real distress and dysfunction in a person's life. Um, so we tend to, overstate our own difficulties and talk about how we've got particular disorders when really we don't. I'm not one to be the word police, but on the other hand, it does tend to minimize the experiences of those who do struggle with those particular things. So, for instance, I've got a thing. Um, if I go into someone's house and need to use the bathroom, I am not going to pee in that bathroom until I've checked behind the shower curtain. There's nothing I hate more. Well, okay, that's an over exaggeration, but there's few things that I hate more than a closed shower curtain because the one time I don't check behind there, there's going to be a dead body. It just will, right? That is a quirk of mine. Now, it is a little obsessive. It is a little compulsive. I feel like I need to check behind that shower curtain before I go to the bathroom. Is that obsessive compulsive disorder? No, it is not negatively impacting my life. If I really were in, a situation where I just had to go to the bathroom right then, I could go to the bathroom still without checking behind the curtain. I wouldn't love it, but it'd be fine. I could still do it. Obsessive compulsive disorder is at a whole different level, right? Where a person is struggling to function, unable to function normally due to the presence of these intrusive thoughts and these behavioral loops that they get stuck in order to try to deal with those thoughts. So that's what we're talking about. You've got these obsessive thoughts that just won't go away, that are intrusive, that the person can't get rid of, and then behaviors that get enacted to try to deal with that intrusive thought. So you get somebody driving to work who has OCD, who thinks, did I lock the door? I don't think I locked the door. I know I didn't lock the door. Somebody's going to rob my house. I've got to go back and lock the door. And then they will drive back to the house and lock the door again, even though it was probably already locked. But then they'll need to do that 5 times or 7 times or a certain set number of times before they can let go of that obsession and then move on, right? Um, that's a whole different level than what I'm talking about here. And it strongly interferes with people's lives. Okay, so this affects perhaps 1 to 2% of the population worldwide. Um, it seems to come on most frequently in late childhood or your early adulthood. It can be anywhere from mild to moderate to severe and does not appear to differ. There don't appear to be any gender differences here or ethnic differences. Um, Only about 40% of the people who experience the symptoms of OCD seek treatment. Um, so, how do we diagnose it? Well, the person has to have a history of repeated obsessions and or compulsions or both. It needs to take up a considerable amount of time during their day, and it needs to interfere with their life. Right now, the obsessions need to the features of these obsessions. They need to be intrusive. They need to feel like they are coming from outside the self. And they need to be very difficult to ignore. So when a person tries to ignore the obsession, it tends to cause high levels of anxiety. And the things that a person tends to be concerned with in terms of what these obsessions are, most frequently it's dirt or contamination, but it can also be thoughts of violence or thoughts of imposing order or religious thoughts or sexual thoughts, right? Now, you pair some of these with compulsive behaviors designed to reduce the anxiety associated with these obsessions, and you can see how that could be really intrusive and problematic. You've got intrusive sexual thoughts that you can't get rid of, and the only way to relieve that is through masturbation, regardless of where you are or who's around, or through grabbing people on the street. I mean, you can see that's a side of OCD we don't talk about much, but it absolutely exists, and you can see why that would be problematic and disruptive to a person's life, right? Okay, so the compulsions are frequently related to the obsessions, right? These are things that a person chooses to engage in, but that feel they. When I say they choose to engage in them, it is a voluntary behavior. It is not something involuntary. It's not a knee jerk. This is something that the person has to go out and do, but it feels compulsory. It feels like they have to do it, like they can't stop themselves, or bad things will happen. Um, One of the interesting things about OCD is that people will frequently realize as they are engaging in these behaviors that they are acting unreasonably. Um, um, but they feel like they need to do them anyways. And while the performance of the behavior tends to reduce the level of anxiety associated with the obsession, it usually only works for a short period of time. And so these turn into things that a person develops a ritual around, where they do it a certain number of times because they know through experience that that's how many times they have to do that thing in order to feel better, right? And you can see the things there. And once again, these are going to be related to the obsessions. It's cleaning things, or checking things, or putting things in order, or counting things, or touching them in order to reduce that anxiety. Now, why does this happen? Well, from the psychodynamic perspective, it's you've got warring desires. You've got what the id wants and what the ego wants, and that back and forth. Um, and the different defense mechanisms that either the id or the ego will use. Um, you're reducing anxiety by acting out these behaviors, right? But that's where that anxiety comes from, is the battle between the id and the ego. Freud, if you think back to his psychosexual stages, he strongly related the occurrence of OCD with being anally fixated. But since that is his stage theory is one that we don't really adhere to anymore because it doesn't have any research support, that's you got lots of psychodynamic therapists who will disagree with that assessment, Freud's initial assessment, that it's related to that stage. How do you treat it from a psychodynamic perspective? Well, not effectively. Once again, you can try and use these free association techniques to try to get to the root cause of what is causing the anxiety and the unusual behavior. But generally speaking, it's not terribly effective. And so, generally speaking, people will not seek out a psychodynamic therapist for their OCD. Cognitive behavioral perspective says that we all have undesired, unwanted thoughts, but that when they become too distressing or cause too much anxiety, um, a person may choose or decide to reduce that anxiety by acting out the behaviors that are associated with that thought. So the therapist from the behavioral perspective, the cognitive behavioral perspective, is supposed to address those irrational thoughts and try to train the person into more effective loops of behavior. Now, there is some interesting, you talk about it from just the behavioral side, there's been some interesting work done using exposure and response prevention exercises, where essentially you expose the person to the obsessive object and don't allow them or prevent them from engaging in the obsessive behavior that's designed to reduce that. And then it's very difficult for the person. They hate it. They really struggle with it. But over time, the obsessive behavior tends to be reduced. There were some case studies that were done where a woman who was obsessively cleaning and that was causing real problems was essentially put in a filthy, dirty room, and the water was turned off, and she was not allowed access to cleaning materials, and she lived in there for 2 months and really hated it. But over the course of those 2 months, her levels of obsessive cleaning declined to more reasonable, functional levels, to where she was then able to go back out and live a more normal life. It didn't eliminate her cleaning tendencies entirely, but it reduced them to a more manageable level. And that same kind of treatment is effective in 50 to 70% of cases of OCD. So that's a pretty commonly used treatment. Biological perspective, what's going on? Well, early on we were looking at twin studies and family studies to see whether this was something that ran in families, whether it is where there is a genetic component. And it appears that there is. This is something that is there's at least some genetic component to. And what's going on that causes these obsessive thoughts that then are followed by compulsions? Well, it appears that folks with OCD have abnormal levels of serotonin activity, and that there may be some differences in some of the structures in their brain related to reward and behavior maintenance. And so that's something we're still trying to figure out exactly what's going on there. But in terms of treating it, there's been some success with antidepressants that target serotonin. You've got, again, pretty high rates of success. Those with OCD, you get some improvement at least, if not elimination of it, 50 to 80% of folks. But you have to keep taking the medication, or else you have to deal with relapses. The most effective, as with many of our disorders, is a combination of medication and talk therapy to help the person not only immediately reduce the incidence of the troubling behavior and of the obsessive thoughts, but then teach them modes of behavior that are more effective, retrain them essentially how to respond in scenarios where their obsessions are likely to be triggered, right? Now, there have been, with the latest version of the DSM, the DSM-5, there are other disorders that have been listed as related to obsessive compulsive disorder. Hoarding disorder is one of them that didn't even really get much attention at all. It wasn't in the DSM until the DSM-5 was popularized with the prevalence of those TLC shows, My Strange Addiction, Hoarders, things like that. I'm not a fan of TV shows that treat people like circus animals, but at the same time, it did bring more attention to it, to where it's actually receiving more treatment, more attention, more study than it was before. So, I don't know. Trichotillomania, excoriation, body dysmorphic disorder. These are all based on the best knowledge that we have right now, related to OCD, and therefore susceptible to treatments that are similar to the successful treatments for OCD. Okay, that's all I've got for Chapter 5. Once again, we didn't cover everything, so make sure you're reading through your chapter, and we will see you next week. Thanks, folks.